Kelty, if okay with you, we can hit go. So the way we generally start is we do a quick round of introductions, and then we turn things over to you um, to really you know absolutely no reason to show slides, and you just want to talk through the topic, and then we'll open it up for questions. Is that okay, Shawn?
Yeah, that's fine, Eddie. Sure.
Great. So you know me. Why don't we go to Renee Pellerin?
Sorry, I just had to unmute. Hi, so you're from Ottawa, so you understand what the CBC is. So I'm a journalist who worked for many years at the CBC and did a lot of health journalism, consumer journalism at the CBC, and was last the head of the health unit for CBC News, which meant I had a staff of radio, television, and online reporters doing health stories. When I left the CBC, I decided to write a book, and I wrote a book about mammography screening and the problems with overdiagnosis in breast cancer.
Thank you, Renee. Why don't we go over to Lorianne Hardcastle?
Hi, everyone. I'm Lorianne Hardcastle. I am an associate professor at the University of Calgary. My primary appointment is in the Faculty of Law, and I have a cross appointment to the Cummings School of Medicine. And my research focuses on health law and policy.
Thanks, Lorianne. Welcome to one of these evening get-togethers. Donna, are you able to unmute? Not sure Donna is there, but we can always come back to her. Guylaine, would you like me to introduce you, or would you like to introduce yourself? Or
I can introduce myself. I'm a physician from Gatineau, that's in Quebec, near Ottawa. I'm on the Canadian Task Force with Eddie. I'm also with the Choosing Wisely Canada. And I'm not feeling too good tonight, so I'll keep my camera off. Okay.
Right, and we're not going to catch anything from you, Guylaine, so it's all good. Let's go over to, we have a guest who's not yet formally on the local planning committee. Sam Vaillancourt, also a McGill grad, emergency doc in Toronto. You want to go ahead, Sam?
Yeah, I just took the few minutes before you joined to barge in and introduce myself, so I wouldn't be a stranger. But yeah, so I'm an emergency physician at St. Michael's and researcher, and glad to be here.
Awesome. Kelty.
Yeah, hi, I'm a research assistant for Dr. Lang and the ESCN, and I'm currently doing my MPH in epidemiology. So I just really love to be a part of these conversations.
Great. And last but certainly not least, from Victoria, BC, Alan Castles.
I'm Alan Castles, and I'm in Victoria. I work at the Therapeutics Initiative at UBC, and I've written a lot about overdiagnosis. I wrote a book on screening about 8 years ago or so called Seeking Sickness, and I've been to pretty much most of these meetings, except for the one that was supposed to be in Australia. So.
Great. Now, forgive me, but I forgot that Geneviève Bois is joining us tonight. I don't know, Geneviève, if you're in the Quebec Arctic, but Geneviève is probably...
I'm not.
You're not? Okay, well, I'm glad that you're back in Montreal. But I believe that Geneviève and Alan are probably, maybe Guylaine as well, are amongst the individuals who have been to many of the previous PODC meetings, where Calgary looks, if I'm correct, it'll be the 11th international gathering of the PODC. Geneviève, go ahead.
Hi. Yeah, no, so I'm leaving for the Arctic tomorrow, hence the incredibly good resolution of this video call. I'm going to savor it before going to bed Wi-Fi. So I work in what Max do in the Hudson Bay. I'm a GP there, and I also work for the Quebec College on Overdiagnosis and the Canadian College of Family Physician. And Guylaine has been to many more PODCs than I've been. I've only been to 4 or 5, but certainly Australia was a good one not to miss. If I had known it was my last trip for I don't know how many years with COVID, I would have had, even more fun, I think.
That's awesome. And joining us from Toronto, Joel Lechtgen.
Hi there. I do emergency medicine in Toronto, and I've had a long history of involvement in pharmaceutical policy issues, including going to the what may have been the precursor of the overdiagnosis meeting, which was a meeting in Newcastle back in, I can't remember when, 2000 and something.
2005.
Thank you, Alan.
Great, thank you, Joel. So Shawn, you may have a few questions, but I would turn things, if you want, I could certainly, we can turn things over to you for some introductory comments and thoughts, and then there will certainly be a bunch of questions for you.
Well, that sounds great. Thank you, Eddie. And it's good to see Eddie again. As he alluded to, many years ago and many hair follicles ago, Eddie and I were both medical students together at McGill, and we graduated way back in the last millennium. And it's nice to see, and thanks for the invitation, of course. Eddie, I didn't prepare any formal slides, but I could bring them up if you thought that was necessary.
No, I don't think so. Oh, you also, Shawn, you're a little bit on the quiet side. I don't know if maybe you can get closer to your microphone, but honestly, you know, these are very informal. If you need your slides, we can definitely make you a co-host.
No, I
but
don't need the slides.
but if you want to just walk us through, and open it up, that's fine too.
Okay, so can you hear me better now? I'm speaking a little louder as well.
It's better.
Okay, fantastic. So I've had, I guess, before I start though, I just want to make sure I understand the definition you guys are using for overdiagnosis, because, you know, I know in oncology, the definition is a little different than it is in general medicine otherwise. When you're speaking about overdiagnosis, are you speaking about screening for cancer and finding cancers that aren't that important, or are you speaking about misdiagnosing disease and calling diseases things, or overcalling disease when it's not there?
That's a great question, Shawn, and I can take a first crack at it. What we are discussing is the much more rampant, insidious, ubiquitous problem of overdiagnosis. And but in its nutshell, it's about labeling someone with a condition where the harms are not only exceed the benefits, but there may only be harms. And that comes through a variety of ways. It's best studied and quantified in cancer screening, but we know it occurs in attention deficit disorder, in many mental health illnesses. But you know, interestingly, one of the folks on the International Planning Committee, John Brodersen from Denmark, has a great paper in BMJ called overdiagnosis, what it is and what it isn't. And they're trying to stay clear of the definition. You know, it's not about false positive testing. It's not so much about misdiagnosis. It's about medicalizing the normal experiences, and it's about changing disease thresholds so that you count more people in and get more people get treated. So it's a pretty broad definition, but one of the things I was going to ask you about is how asthma diagnosis fits into that current understanding. So Guylaine has a lot of expertise in this, and so do others. Anyone want to add to what I tried to explain as what our view of overdiagnosis is? Is that helpful, Shawn?
Yeah, that's very helpful. Thanks. No, I understand it well now. I'll tell you how I got into this field and how I grew interested in it. And then I'll describe a little bit about some of the research that our group has done in this area. And hopefully it'll be of interest to you guys. I'm a clinician investigator. I do clinical research and epidemiologic studies, and but I do clinical work as well. And I would find in my clinical practice, I'm a respirologist in Ottawa, I would see a lot of people refer to my practice, and the referral would come in from the family physician or from the emergency physician or whoever it came from. And, you know, the typical referral would be, please see this 45-year-old gentleman who's had asthma for 3 years and his asthma is still bothering him and he's poorly controlled and he's still short of breath. And I would see this person who gets referred to my practice with this stated diagnosis of asthma. And the first thing I would ask them is, well, have you ever had tests to confirm the diagnosis? Have you ever had spirometry, which is the usual preliminary test we do to confirm asthma by giving, you know, doing a pre and post bronchodilator spirometry? And most of these patients would say, no, I've never had any tests. The doctor just made the diagnosis based on my history. And then we would go ahead and test these people. And if their test was negative, we'd go ahead and do a confirmatory test, which is called the methacholine challenge test. You only do that if spirometry doesn't confirm asthma. And oh, thank you, Eddie. Sorry, not everybody's a physician here. You're absolutely right. Spirometry is where you blow into a machine and we measure how fast you blow. And if you have asthma, your bronchial tubes are narrowed and you blow slower. So bottom line is we would do the testing. I would do the testing in my clinic and it would turn out the patient never had asthma. So this person's been diagnosed with asthma for a number of years, has been treated with asthma medicines for a number of years, including in many cases, you know, high dose inhaled steroids, bronchodilators. Sometimes they've had recurrent episodes of treatment with oral prednisone, but the patient never had asthma to begin with. They have something else. It could be another pulmonary disease, it could be a cardiac disease, or it could be something as simple as anxiety causing shortness of breath, or panic attacks causing shortness of breath. So that's where the thought for this study came from was, you know, if I'm seeing all these people in my practice who are referred with the diagnosis of asthma, how many may have been overdiagnosed? In other words, how many people have been diagnosed with asthma when they never actually had it? The other interesting part about asthma is that it's a disease that we can sort of relapse and remit. In other words, asthma is a chronic disease, but it's a disease that can spontaneously get better on its own. And the other thing I see in my practice is people who've been maintained on asthma medicines for 25 years and who feel perfectly fine, but they never get taken off their asthma medicines because nobody ever tested them to see if they still needed them anymore. So that's also potentially a form of overdiagnosis because you've labeled a person as having a chronic disease, an active chronic disease. Excuse me. Sorry. If this continues, I may have to go get some water and come right back down, but I'll keep going. So doctors can label someone as having an active chronic disease, can treat it indefinitely, and never retest to see if the disease has actually gone away. So that's how I got involved, or how I got interested in the field. And the bottom line is that our group has done several studies now, and some of them I think you have in the handout that Kelty sent you guys, the attachments. We've done several studies whereby we've randomly recruited asthmatics from Canadian communities. We recruit them by random digit dialing. That is, we call them at home and we ask for volunteers. And in the last study, we asked for people who've been diagnosed with asthma within the last 5 years. And then we put them through an extensive testing protocol to see if they really had asthma or not. And the bottom line, to cut to the chase, is that a third of the patients who are labeled with active asthma in our community don't seem to have asthma when you put them through an extensive diagnostic workup. And these people were able to taper off their medicines and in fact completely stop their medicines. And the vast majority, more than 90% of them, stay off medicine for a year without any ill effects. So again, it implies there's a lot of overdiagnosis and overtreatment of asthma in Canadian communities.
So that's fascinating, Shawn. And you know, if anybody has questions, just, you know, raise your hand or whatever. I mean, Alan, go ahead. Yeah.
Just a quick question. What is the psychological impact of telling someone they've got asthma when they don't?
Well,
Other than the wasting the money on the drugs and having to do the drugs, I'm just curious about how you're telling someone they've got asthma. What does that mean to their lives?
well, it's a good question, Alan. I didn't really study that directly. I want to be honest with you. We didn't study the neuropsych aspect of this. But as you can imagine, people who are told they have asthma, some of them end up modifying their behavior, not always in a good way. Sometimes it's a good way because they'll quit smoking, or maybe they'll get rid of the cat, which is aggravating the asthma, or maybe they'll stop riding horses, which is aggravating their asthma. And those aren't bad things. But some people will do other things that they shouldn't do, such as stop exercising because they're told they have asthma and they don't want to provoke an asthma attack. So they stop exercising. Alan, if you give me 1 sec, I'm just going to go grab some water from the kitchen because it's really dry in here and I'm having trouble. Can you give me 1 minute? I apologize, Eddie. I'll be right back.
No problem, no problem. While Shawn's getting some water, first of all, welcome Jim Dickinson, who's enjoying a nice glass of red wine, I'm sure. I hope it's an Australian vintage that you have there, Jim. Just to update you on what's happening with the conference. So the University of Calgary has decided not to hold any face-to-face events in 2022. And there's still a strong desire, sorry, 2021. 2021, sorry. There's still a very strong desire by the Scientific Planning Committee to hold a face-to-face meeting. So I've got a discussion with Oxford and Calgary tomorrow. I think the way this is going to play out, and interested in your thoughts and feedback, is that we're going to have probably a series of regular seminars, maybe every 2 months, with a maybe more intensive event, virtual event in September. The Australians are very interested in that because they want to make sure that the early career researchers have a venue to present abstracts and that people like Shawn Aaron can submit panel and workshop ideas that can be featured virtually. And that will be a kind of a lead up to what I hope will be a really exciting COVID-free post-vaccination face-to-face event in Calgary in June when the flowers are at their peak and the mountains are beckoning. So I don't know if there's any thoughts on that before we get back to our discussion with Shawn, but I think that's probably the way things are going to play out. Joel?
So you're talking about June of 2022?
Correct. Because it's
okay.
The feeling is there would not be enough freedom to travel or vaccination to hold a face-to-face in June of this year.
All right. I mean, I still have the same concern then, which is that in a lot of the low and middle income countries, vaccination in the middle of 2022 will still be spotty, and you're going to be excluding people from those countries from coming to a face-to-face meeting.
That's a good point, Joel. And it could, for those reasons, if that helps, it might get pushed to the fall of 2022 or a full 12 months later. I'll bring it up tomorrow, and it's certainly something that's high on the minds of the International Planning Committee because they are very keen to the problem of overdiagnosis in low and middle income countries, and it's very important that they have representation. I mean, this is after all something that the WHO is very concerned about and supports this conference. So that's going to be an important consideration for sure. Okay, and I was going to say something else. Yeah, so we'll see. Hopefully, we'll find that sweet spot where travel restrictions will not hopefully be a hindrance to wide participation. Good. So, any other thoughts or comments on the timing of the meeting? All right, hearing none. Well, why don't we go back to our discussion? Shawn, you were talking about the psychological impacts of labeling. Did you want to pick it up, or?
I would, because Alan asked the question and I interrupted with my voice hoarseness.
Sorry, Jim, did you have something you wanted to say right now?
Could I just make a point? I agree with Joel's concern about the people from developing countries, but I would just wonder whether the healthcare professionals in those countries, the ones who would actually travel, would be able to get vaccination. So that although their country might not in general, whether the healthcare professionals would be likely to have vaccination, if that wouldn't stop them coming to Canada.
Good point, Jim. One thing I wanted to actually mention was that one thing that seems to be carved in stone is that Copenhagen is hosting PODC in mid-August of 2023. So the window for a face-to-face or something would be limited in Calgary to 2022. So thanks for all those thoughts. I'll transmit them tomorrow. Back to you, Shawn.
Yes, thank you. So Alan had asked about the psychological effects of overdiagnosing or mislabeling someone as having asthma. And I had mentioned that one is the behavioral issues, that patients may stop exercising. Another one, which and admittedly we didn't study this, but theoretically other people have looked at this and have shown that there is increased levels of anxiety and depression that occur in people, especially when they're labeled with a chronic disease, especially when they're young, as most asthmatics are. So I think the psychological impact can be quite broad and important. And so removing misdiagnoses and removing the labels or overdiagnosis would be important in these people. They feel, the people in whom we interviewed, who we ended up removing the diagnosis and stopping their meds, were relieved and felt very grateful.
Yeah, I mean, sometimes people want to diagnose to make them, to give them an explanation for what's going on. But yeah, that was one of the common themes when I was writing about screening, is that so much of the psychological impact of labeling somebody is never really in the calculation. When you tell a young woman that she's has breast cancer when possibly she doesn't, and then labeling her as somebody who is high risk, she ends up living under a dark cloud, possibly the rest of her life. And I think that's why we have to be so careful, so ultra careful about labels, because what it does to people psychologically.
I mean, I 100% agree.
Yeah, and Joel has made the point about the DeFasco study, about that people given a diagnosis of hypertension, just being given the diagnosis led to them having more absenteeism and so on. Yeah. But the other one that we published, just the abstract, unfortunately so far, is that it costs. You get insurance problems. Insurance in places in America, it means that you may not be able to get health insurance at all. But even in Canada, it may mean trouble in buying a house because you have to have health insurance on your mortgage. It may cause trouble in traveling because you may have to have health insurance for travel. So it changes a whole lot of aspects of your life. And if you just want to get life insurance, it may be loaded. You may have to pay twice as much. So, there are direct financial costs of having a label of these types.
Absolutely. I mean, I think the other thing I didn't discuss with you guys, which may be important, is many of these patients were overdiagnosed, but we also found that some were misdiagnosed. In other words, they really truly had significant cardiopulmonary disease, that is lung or heart disease, that had been labeled by their physicians as asthma when they never had asthma. And so that's something else that, another indirect problem with this overdiagnosis is the fact that the missed opportunity cost, the missed opportunity to actually figure out why the patient is having shortness of breath or cough or symptoms, and the missed opportunity to make the correct diagnosis and treatment. So, overdiagnosis, at least in respiratory disease, has many facets. Some of it, as I said, is people who really never had a problem to begin with and were completely overdiagnosed. Some were misdiagnosed with asthma when they had another disease. And then others had asthma, but they went into a prolonged sustained remission, and that remission was never picked up by their physician. And so the treatment was continued needlessly. You know, that's what we found when we dove deep into our study subjects.
Thanks.
Thanks, Shawn. Renee, did you have a question or?
Yes, I did actually. One of the papers that Eddie sent to us was about COPD, and I wonder if you could talk about overdiagnosis on that condition.
Yeah, absolutely. You know, the studies suggest, and I haven't done these studies myself. I've mostly done the asthma studies thus far. But the studies suggest if you look at veterans in the United States who go through the Veterans Affairs hospitals, the VA hospitals, or if you look at, there's other studies done in Europe where they take samples of patients who've been diagnosed with COPD, and they actually physically test them to see if they have COPD. And again, the test is using spirometry, where you blow into a tube. It's sort of the same test. It's the equivalent of testing, you know, when you test blood pressure, label someone with hypertension, you have to put a blood pressure cuff on and test their blood pressure. When we label someone with COPD, we test how fast they blow into the tube with this test called spirometry. And the bottom line is, if you take random samples of people diagnosed with COPD in the VA hospitals, 30% don't have COPD when you test them, and similar results in Europe. It's about 30 to 40% of people labeled with the condition don't actually have them.
Wow. So what do they have?
Well, I didn't do those studies. Unfortunately, I can tell you what the asthmatics have who didn't have asthma, because I did that study. But the studies were not as complete as we would want. So they didn't actually test to see what those people had. You know, I can imagine that many of the patients had other conditions that could cause shortness of breath, like heart conditions, for instance, and they were falsely labeled. But I can't say for sure. I mean, I know you guys aren't interested in this, and I'm not going to bore you with it. But the other corollary, or the you know, the left hand to the right hand, is the issue of underdiagnosis, and there is quite a lot of underdiagnosis of lung disease, asthma, and COPD in Canada and the U.S. as well. And I'm also doing those studies right now. But I know that's not your guys' interests. But there are a lot of people walking around in the community who have COPD or asthma and who haven't been labeled, and they really should be labeled.
Genevieve has a question.
I wonder, how do you differentiate that it was like truly a misdiagnosis versus, you know, the test not picking it up? Because like no test is perfect. And we, like in my clinical practice, I do have a certain number of patients who have had normal spirometry once or twice, and you know, they behave like asthmatics. And
yeah,
no, you know, every 5 years somebody refers them to RESP, and they return, you know, with a paper saying, I don't know what the hell you're talking about. This person doesn't have asthma. But I see them 4 times a winter, you know, needing very urgent intervention and being in really poor health. And I wonder, you know, there must be a percentage of people that just have a false negative on this test, because, you know, despite my attempts at, you know, de-prescribing their puffers, I had to accept that, you know, some of them really need them, even if they tested negative twice.
You're absolutely right, Genevieve, and there's no question. So if you just look at pre and post bronchodilator spirometry, which is the typical test that you would order in your practice, I imagine, it only has a sensitivity for asthma of 30%. So you're going to miss 70% of your people with asthma with that test, because asthma is a variable disease. You could be perfectly well one day, and then 3 days later, you're exposed to your neighbor's cat and you're wheezing and you're short of breath. And if you test the patient on the day they're perfectly well, their test is normal. So you're absolutely right. But what we did in our study, Genevieve, which, you know, you'd have to read, we first tested them with pre and post bronchodilator spirometry. Then we did what's called a methacholine challenge to try to provoke asthma. that has 98% sensitivity to diagnose asthma. So it only misses 2% of people. But if they were negative at that point, we then tapered their medicine. We have their asthma medicine. We waited 3 weeks. We redid a methacholine challenge. And if they were still negative, we tapered them again and we redid the methacholine challenge a 4th time. So by the end, now this isn't typical testing you'd ever do in the community because it's expensive and it's crazy. But in the study, we had to do that. And we only took away the label after 3 months of testing. And then even after that, we stopped all their asthma medicines and we followed them for a year for clinical decline. And we retested them with methacholine challenges twice in that year. So these are not people who we ended up mislabeling as not have asthma. These people did not have asthma.
No, I mean, I understand that, just a spirometry wouldn't be enough. And for sure, after this protocol, we'd be very, very, very reassured that it's not like 7 false negatives in a row.
Right.
So so this way we could say that this 30%, is probably 99 point something percent, true misdiagnosis, and there's nothing left after that many rounds of testing, or almost, that would be like persistent false negative.
Exactly. The other thing we showed is that, I didn't get into all the details, but in all the patients who came into our study, we contacted their primary care physicians and we bribed the primary care physicians with a $25 Chapters gift card. And it's incredible what doctors will do for $25. They'll do anything. So we actually had them send us their notes and any tests the patients had at any time throughout the time of their diagnosis or before or after their diagnosis. And we asked the doctors to send us the tests that you've done and your notes that confirm the diagnosis of asthma. So we asked for any spirometry tests, any peak flow tests, any methacholines, all these things you would do to try to confirm asthma. Bottom line is 50% of Canadians who are diagnosed with asthma never have any testing. They're just diagnosed based on clinical history. They've never had a test. So, I mean, as a respirologist, this disturbs me because I don't think any primary care physician would diagnose diabetes without taking a blood sugar or at least doing a urine dipstick. But in primary care and in other areas, people are labeling people with asthma without ever actually confirming the diagnosis with an objective test.
Thanks, Shawn. You were about to speak to what the most common real diagnosis is, or what's going on most of the time, or most of the time. I'd be particularly interested on anxiety, mental health as an alternative diagnosis, because one of the overdiagnosis paradigms is that sometimes prescribing something that's being promoted by industry, or that's the easy way to move a patient through the office, might end up with this overdiagnosis situation and months, if not years, of overtreatment and unnecessary treatment. So, and any thoughts on that, and whether that's how much of a player that is? And
yeah, that's a good question. We found about of the people in whom we excluded the diagnosis, and there were more than 200 patients in whom we were able to rule out asthma. 10% were diagnosed with anxiety or hyperventilation syndrome. So 10% clearly had mental health reason for their symptoms.
But that wasn't the most common?
No, actually the most common was when they were, we had them all see respirologists. The most common was these people became asymptomatic. In other words, they had no diagnosis. They were perfectly well. We took them off their asthma medicine. They remained well, and the diagnosis was nothing.
Interesting. So has that translated into a choosing wisely recommendation? That you might be cautious before labeling someone an asthmatic, or make sure you have objective testing, or you can't. You might need time to really make that diagnosis, right?
Yeah, no, you're absolutely right. I guess I'm at fault. I don't know that I've advocated enough at a policy level to help change the world. This is one of my major shortcomings in my career, is that I do the studies and then I move on.
Shawn,
it's terrible.
But it's not too late, Shawn. You can submit a proposal to the conference and work up a panel with your colleagues and say, what I wish I could do now and that I know what I know about overdiagnosis.
Yeah, no, I'd be happy to do that, sure.
That's awesome. Jim has his hand up.
I'm wondering whether perhaps also there is more variability in asthma than we first think. That maybe somebody gets a viral infection of some sort, plus they have maybe an allergic tendency, and they get the asthma reaction, and they do respond to the asthma treatments. And we may or may not get around to sending them for testing because they're getting better with the treatment we give them. And maybe that goes on for a couple of winters. And then as they get older, then maybe that reaction goes away again. You know, what is the natural history? And I get the impression there always was the story of kids who got asthma and then grew out of it. Yeah. And then other people said, oh no, that doesn't happen. I think there probably is a range of people who have different natural histories.
100% agree with you, Jim. I mean, there's no question. I mean, we know that kids grow out of asthma, especially boys. Asthma is more prevalent in boys before puberty, and then they go through puberty and they hit adolescence and they grow out of it. And in fact, after puberty, asthma becomes more prevalent in girls, in women. There's no question people grow out of asthma. And we know from studies that have been done that roughly 10% of adult asthmatics go into a sustained remission at some point in their disease course. And we were able to show in the study that I just told you about 16% of the people in whom we excluded asthma, when we contacted their family doctor and we got the test results, the tests that the family doctor had done were appropriate, and the test showed asthma. So the test showed asthma 3 years ago, and now today we've put this person through the ringer, and we have no evidence of asthma. Clearly, they went into remission, as you said. So asthma is a variable disease, and that's what makes it tricky. And that's also, why even though my studies I think are definitive, I can't be dogmatic about this, and I can't blame doctors because they may have been right in the first place. It may just be a question that the person had asthma 3 years ago, but right now they're in a sustained remission and they don't have it anymore. And I'm not, who's to say they won't get it again 2 or 3 years down the line? They might.
Genevieve?
Should this mean that, like, if we're looking at a recommendation, we should suggest like few years attempt at deprescribing or retesting? And how would that be? Like, because it's already like taking me 6 months of hoop jumping to get a methacholine challenge, when it's not COVID and PFTs are actually accessible because nobody's worried that we're going to aerosolize some COVID everywhere. Like right. It's really, right now everybody's diagnosed as asthma clinically because the spirometry is, an invention at this point. But, even in this elusive post-COVID, COVID era, how would it be perceived if I send people for repeat testing in the attempt of delabeling them?
Yeah, that's a great question. And I mean, we had a delabeling protocol in our study, but it's not practical for real use in clinical practice because it's just too intensive and too costly. I would say if you want the best response in a patient who has been on long-term treatment and is clinically well and has no symptoms and has not had an exacerbation in the last year or two and feels well, you could, if you have access to spirometry, you could do spirometry. if the spirometry is normal, at that point you have their asthma medicine. You have a follow-up in 4 weeks' time to make sure they're okay. And if they still feel perfectly well, at that point you could consider stopping their asthma medicine. That would not be unreasonable. And in 30% of patients, based on my studies, you'd be fine to do that without any ill effects. So it's practical, it's easy, and it's doable.
Shawn, it reminds me a little bit of one of the most well-known speakers at this conference is a psychiatrist named Alan Francis. And he's famous for a phrase. He's saying, you know, when you're making a diagnosis in mental health, you should make it with a pencil. Because you might be erasing it. So, yeah, write the diagnosis with a pencil. So there's some similarity. And by the way, Guylaine is putting some awesome stuff in the chat window, some recommendations related to COPD and initiation of long-term asthma medications for asthma. So very, very valuable and a good intersect. Shawn, I don't want to put you on the spot, but I wonder if I could just shift gears a little bit and take advantage of your knowledge as a respirologist. I have a hunch, I'm not sure, but I have this sneaking suspicion that we have a sleep apnea issue. And part of the problem, at least in Calgary, is that there is a very, very close connection between the sleep labs, the prescribers, the people who do the CPAP machinery, and there's a potential danger there of you know, moving the needle on what's true obstructive sleep apnea in a way that may be more provider-centric than patient-centric. So, I mean, I tried to look this up. There's really no literature on this. And then again, there's no literature on overdiagnosis of coronary disease, or very little literature on overdiagnosis of coronary disease, because it's not something a respirologist might want to look at too hard. Do you think there's a lot of people walking around with their sleep apnea machines who don't really need it?
Yeah, and you know what, Eddie? It's like the people who walk around with their inhaled steroids and don't really need it. You know, they declare themselves by being non-adherent to the treatment. Okay, so there's a lot of people who, like you said, are diagnosed with mild sleep apnea. They may not even be sleepy during the daytime. They may have been sent to the lab because they're overweight and their family physician said, well, this is a risk factor for sleep apnea, so I'm going to get you tested. So they're not sleepy, they're not symptomatic. They go through the test, the overnight polysomnogram. They're found to have mild sleep apnea, and the doc prescribes a CPAP machine because that's what they do. You know, they find a problem and they treat it. And then the patient votes with their feet because the CPAP machine gets worn the first night, it might get worn the second night, and then it goes into the closet. And it's never used again.
And do we have any data on that? Like what proportion of CPAP machines are collecting dust in closets?
Yes, I believe the numbers range from 50 to 60%.
Interesting.
What I find with sleep apnea is that the respirologists who test it don't actually ask people if they have allergic rhinitis. And I find very often if you treat the allergic rhinitis so they can actually breathe through their nose, their sleep apnea disappears in a proportion. So that, you know, one doesn't actually need to check the condition of the nose as well as the lower respiratory tract.
Yeah, no, I'm sure you're correct on that. I mean, you know, people with nasal obstruction are going to mouth breathe and they're going to snore. So there's no question. But, you know, Eddie, patients are smarter than the doctors, right? So the patient who tries the CPAP machine and doesn't notice any benefit is going to quickly stop using it. Same thing for patients who are mislabeled with asthma. Their doctor yells and screams, well, not yells and screams, but I'm using strong language, but their doctor tries to aggressively educate them about asthma and the need to take a daily inhaled steroid. But if the patient perceives that it's not working and they're no better, and it's not helping them, they're going to stop the medicine. We actually showed that one of the predictors of overdiagnosis is the patient who is non-adherent to their asthma medicine because it's not working.
And then there's the patients like my mother who's got mild dementia, has the counter on the Advair discus, and the pharmacist knows how often she's used it. And so when she doesn't use it enough, she gets browbeaten into you have to be compliant with this. It's
yeah.
I see Renee is sorry to cut you off, Shawn.
Oh no, I'm happy to let Renee speak.
No, I just have a question, which is, are there drug interactions or drug side effects and or drug interactions that cause symptoms that present like asthma?
Yes, they are. So there are drugs for blood pressure control called ACE inhibitors. They're common drugs. They're also used for heart failure. They'll cause cough in about 5% of people. And cough is also often misinterpreted as asthma or misdiagnosed as asthma, and it's from the ACE inhibitor. Beta blockers, which are used for hypertension and for control of heart failure and coronary artery disease, can also provoke asthma. They can make asthma and COPD worse in some people. So there are some drugs that will either mimic asthma or make underlying asthma worse.
And I think, Jim, did you have another question?
I think that this really illustrates a point that I find myself making to residents a lot of the time, which is that diagnosis is a way station on the road to management. The diagnosis, they're taught in medical school that diagnosis is almost an end in itself. And actually diagnosis is mostly irrelevant to patients. What they want is something to fix what ails them. And sometimes we can fix it without ever making a diagnosis. Other times a diagnosis is quite useful to help us choose the right treatments, but not always. And ultimately what matters is, can we help the patient? And if diagnosis is useful to do that, great. If it isn't, well, throw it out. And we need to sort of get away. Unfortunately, medicine as a profession is very focused on diagnosis because it's actually quite useful, particularly for the sort of patients who get into hospitals. But in general practice, a lot of the time, it isn't actually necessary. And we are better off not making diagnoses that aren't terribly helpful. We should just focus on what will help the patient.
Well, you're right. I mean, unfortunately, even the way, I don't know if you guys use EMRs, but our electronic medical record in our hospital is all diagnosis driven. The first thing you have to do is fill out the patient's problem list and list all of their diagnoses from age 5 to age 95. So, you know, you're absolutely right. It's the paradigm has to shift a little bit.
And Sam has his hands up.
Yeah, I thought Jim's point is excellent and actually almost revolutionary in this day and age. Our EMRs are built around that. Our entire specialties are built around diagnosis without clear treatments in some cases. And yeah, so it's a fascinating to think of the implications of that. I think the other thing is when we're thinking about overdiagnosis, I'm very new. I've never been to any of the meetings or anything. So, but it's obviously something that we all think about as physicians once in a while. And I think the idea of removing something is much harder than evolving towards something else. Because as humans, we don't deal well with void, right? And I've done some work measuring patient-centered outcomes, and one of the things is reassurance, and it got me thinking about reassurance. And one of the things is reassurance. If you just tell a patient you just don't have that, but they've come with the symptoms, it's very hard for them to gain closure. Now in medicine, we think of that as being a lab-driven diagnosis, they may experience it, like even just talking about muscular chest pain or pleural catch syndrome or those very benign things. And I make a point to tell them this is not a disease. There's an explanation. It is often changes the interaction in a very complete way by shifting them onto something that is controllable. It's not a big unknown, or there might be monsters there in their mind, but it's actually fixated on something that is benign, controllable, and answers their questions, brings closure to what it is. So that's just a thought that crossed my mind as I'm listening to this.
Very insightful, Sam. Thank you. Great. Well, we're closing in on the end of our time. Any other thoughts or questions for Shawn? Again, very thankful for you to take time off this evening to join us, and very much hoping that you will we'll hear from you during either our virtual event this autumn or and see you here in Calgary in the spring or fall of 2022. Alan, go ahead.
Just one final, I spent about 2 hours today in a meeting with a bunch of PharmD students who are doing presentations about drug policies related to asthma medications. It was very interesting. And especially the fact that so much of the prescribing we believe is inappropriate. Like even if somebody was, an asthmatic or had COPD, the prescribing is probably inappropriate. But I was blown away. I thought I knew a little bit about this topic, but the hundreds of millions of dollars that we're probably spending on inappropriate, like even if you had the diagnosis, you're getting the wrong drugs. Essentially, you're getting perhaps the latest Advair Discus when there's a generic available that's a third the price. Like there's a whole range of things that are happening. Pharmacare in British Columbia is going to bring some policies in that's going to try to moderate the way that they pay for these drugs. But I was pretty shocked. I mean, these kids, when I say kids, the PharmD students had done this deep analysis of how much spending is going on. And I would probably argue that most physicians don't know the cost of the medications that they're prescribing. And in asthma, as you probably know, there's everything from the $15 salbutamol inhaler to the $150 Advair Discus or whatever's out there. There's quite a range. So, I mean, and you might say, well, what's the big deal? Well, the big deal for me anyways, is that if a patient is getting covered by pharmacare or private insurance, they may not feel the bite, but those people, and maybe there's 30 or 40% of the population have to pay out of their pockets. Some of them are going to get sticker shock when they get to the pharmacy with their new prescription for an asthma medication. And that could be really harmful for people. I did hear a story from a physician a few years ago who was telling the story about a young laborer on a building site who had a kind of an asthma attack because of the dust in the air or some kind of reaction. He got sent to the doctor who gave him a prescription, and when he went to the pharmacy, he didn't fill the prescription because it was too expensive. It was $150 or something like that. And he went back to the job site and had another reaction, and then died on the way to the emergency room. And this kind of thing, what I would label death by sticker shock, is really something that we got to get a handle on. Yeah. So, enough of my rant, but
no, that's great, Alan.
Yeah.
And we see some supportive comments in the chat window about contributing to global warming and difficulty for physicians to know what the costs are. And I'm just going to throw something in there as well. Sam's going to know where I'm going with this, but you may not know this, but recently we've uncovered a remarkably effective and cost-effective way of preventing asthma exacerbation. It outstrips almost anything in our therapeutic armamentarium. And I don't know if Shawn even knows what I'm getting at, but it's masking in public health measures. Especially on the pediatric side, our asthma emerge visits and our asthma hospitalizations are down 50 to 60%. And this may have been a fear of the hospital in March and April of last year, but I'm convinced that it's the reduction in viral exposure that's working way better than any puffer you'll get at the pharmacy.
Yeah,
You're absolutely right, Eddie. It's across Canada. The results are the same. The COVID precautions and masking are dropping acute viral infections. Therefore, acute COPD exacerbations are going down. Acute asthma exacerbations are going down. Our respiratory wards, other than COVID patients, are empty. So you're absolutely right. If it was more socially acceptable post-pandemic, we could improve asthma control tremendously just by masking everyone. But I'm not sure that'll go over well post-pandemic.
Do you really think it's just masking, or is it because really
Social distancing.
Most of the causes of the viral illnesses that then stimulate the asthma are not circulating this year?
Yeah. Well, because of social distancing and masking, we're not those viral illnesses. Influenza is almost gone this winter. There's not.
Yeah, I run the Alberta Influenza Surveillance Program.
Right.
And, our research is going to be zilch this year. So one-line paper, there wasn't any. but it's not just that, it's all of the others.
Yeah, RSV bronchiolitis is way down in the pediatric emergency rooms.
Yeah. And it's
Well,
so low. It's clearly not just the masking, because if it was just masking, we might expect, say, an 80% reduction, but they're just not there at all. And that applies to RSV and metapneumovirus and adenoviruses. And, the only one that's left is some rhinoviruses. They're still there. So that obviously it's more able to get through the barriers than COVID is, because it's still present. But of course, once it's reduced to a certain level, then it doesn't spread because there's just nobody to spread to or nobody to spread from. Yeah.
And let's close off by hoping that will also reduce the amount of overdiagnosis in asthma. So I want to be respectful of everybody's time. It's the top of the hour. Big thank you to Shawn, Aaron, for joining us. Applause in the chat windows, if you will. Thank you. It's been great. And Kelty is going to share the YouTube link in a little bit, and we'll feel free to share it with whoever you want. And it's been a fascinating, insightful hour, Shawn. Thank you for answering all of our questions. And I wish everybody a great night.